it to the patient before offering treatment, peak flow rate, because it assesses the severity of asthma. And sometimes for me it sounds, even in the real life, when you ask the patient to do it, like the patient suffering and they need oxygen and you just ask them to do it. But you can give the oxygen, but don't give the treatment. Let them do it, big expiratory flow rate, and then decide the severity. So 33 to 50%, it is acute severe asthma. Less than 33, it is life-threatening asthma. This is something to put in your head. And also, acute severe asthma, they have, of course, respiratory rate more than 25%, heart rate more than 110. And so life-threatening asthma oxygen saturation is less than 92, and the patients can't, it is extremely like they can't speak sometimes even. And the PCO, it is it is normal, yeah. So yeah, the big difference between acute severe and the life-threatening. So the peak flow is going to be normal in this, because normally it has to be low because the patient is breathing so fast. So in the acute severe asthma, the patient is breathing so fast. So CO2 is getting out with the breathing. So that's why they're having low CO2. When the PCO become normal, it means now their lung got exhausted. And if it become high, so this is life-threatening, like near-fatal asthma is extremely serious one if the CO2 increased. So this is one of the things, like when you do arterial blood gases. So any patient who has oxygen saturation less than 92, we have to do arterial blood gases. But in asthma in general, we can do it as a routine, arterial blood gases. But anyone whose oxygen saturation less than 92%, we have to do arterial blood gas. So if, yeah, so this is life-threatening asthma. So it's the same like acute severe asthma, but they have more severe symptoms like cyanosis, exhaustion, confusion, and silent chest, bradycardia. Also, they could have arrhythmia, hypotension. Yeah. Also, we can do just X-ray, but it shouldn't be like, it's not mandatory because it may delay the treatment. So the first step, we will do just arterial blood gases, routine investigations, and we will offer treatment. And here is the treatment steps. Okay, so of course, oxygen for all patients, CMAN station, we will give high flow oxygen, non-rebreathing mask. We will check first, just ask, do you have smoker cough or not? But we're going to give high flow oxygen. And if the patient cannot talk, start treatment, but get senior ICU or help. Yeah, so if the patient can't talk, give the oxygen, start the treatment, and call for help as early as possible. And check trachea and chest sign for pneumothorax. Yeah, so we need to check for tension pneumothorax even in our SIMMAN. So we'll check the trachea and listen to the breathing sound. So percussion is not always necessary, as I said, but it's really important to do the trachea and auscultations. And tell the examiner, I'm checking for tension pneumothorax. And we will give the first steps. So in the asthma, we'll give 5 milligrams of salbutamol. And what's I saying here? Okay, and corticosteroid. So we'll give corticosteroid orally or IV, preferably IV if the patient's not well. 100 milligrams IV hydrocortisone. And 5 milligrams salbutamol. 5 milligrams salbutamol, it can be every 10 to 15 minutes. We can repeat the salbutamol. So in our stations, when you give the salbutamol, the patients when you give the oxygen saturation will improve. When you give the salbutamol, the patient will be absolutely fine. So we don't need to do the rest of the steps of if they brought it exactly the same every time. But just putting in mind, if the patient respond to salbutamol, and we have to give hydrocortisone anyway because it's anti-inflammatory, but we will stop here. So salbutamol, hydrocortisone, finished. But if the patient is not improving after the salbutamol and hydrocortisone, so we can add nebulized ipratropium bromide, 500 micrograms. So the salbutamol 5 milligrams, the ipratropium bromide is 500 micrograms, and it's every 6 hours. Okay, after that, all the rest of the treatment is a senior treatment. So just you will stop in this ipratropium bromide 500 micrograms, and then you said, I'm going to call my senior. If the patient is still not improving, I'm going to call my senior to give IV magnesium sulfate or IV aminophylline, so, or IV salbutamol. So this is senior treatment. We're not going to even to remember the dose because we're not going to give it, but examiner may ask you what next. And even if your patient is not hasn't improved after ipratropium bromide, it means you did something wrong. Revise it. Go again to A, B, C, D, and check the patient again. Check the mask if is it on bilis, and try to see what wrong you did, because normally the patient has to improve quickly, but if it deteriorated so bad, so it means something wrong has been done, and just go back. Don't be afraid to go back to the ABCD, start from the beginning. Airway, ask the patient, are you there with me? Can you speak? So I can see, even if the patient is saying very few words or confused, it's still airway is better if they can speak. So I can see that my patient has a better airway, and you would make sure the mask is well fitted in the so make sure so if you do something wrong, they may not improve the patient until, because when I did my exam, I heard some people in the lift saying I sent the patient to the ICU and still he's not fine. So when you do something not good, the examiner will not fix it for you. For me, just when I give the salbutamol, the patient has become fine. Yeah. So we don't give routine antibiotic, but if the patient has fever, so in our when we check the temperature, if they had any fever, we can, when we listen to the chest as well, if there is any abnormal breathing sound, so we can consider giving antibiotics. Yeah, that's it. Okay, so yeah, so we will do same steps we did yesterday: airway, breathing, and circulations, and we don't forget the temperature and everything, but take it step by step. If the patient, for example, improved in the B, so we will do the C, because the cannula, we need to know if they have hypotension or not. So we'll do all the C, but if the patient improved already, so just in the C, we'll speak about the investigations, and we will continue with the history. We're not going to do the E and D, the D and E. Okay. Okay, so